about to go for complete axillary dissection or radiotherapy? Who support to go for axillary dissection? We're voting about the two speakers, their opinion. Axillary dissection again. Okay. Radiotherapy. One hand. Still the majority is convinced toward axillary dissection. Thank you.
Now we move to the next third question about TMBC after full course neoadjuvant treatment with less than PCR, whether to give more systemic therapy or no need at all. Professor Joseph Gligorov from France is going to speak about more systemic therapy, and Professor Mathieu Pro from Switzerland is going to give the opposite view.
So thank you very much again for the invitation, and I will begin with the statement of last year, if you remember, because we have the same discussion concerning the topic of the neoadjuvant treatment in triple-negative breast cancer with my friend Mathieu Pro. And then I will just remind you the conclusion from last year. And we stated that first, neoadjuvant treatment should be mostly proposed to all operable triple-negative breast cancer because chemotherapy is mostly indicated for all triple-negative breast cancer. There is no detrimental effect of neoadjuvant versus adjuvant chemotherapy. PCR is a surrogate marker of overall survival. And finally, the optimal situation in neoadjuvant setting is the optimal situation to evaluate new treatment strategy. So according to that, then we have moved on and say, okay, if neoadjuvant approach is the most interesting one, what to do in case of absence of PCR? And do we need to have more treatment? And I will try to convince you, yes. The first thing is that we know that the impact of the pathological complete response in overall population treated in neoadjuvant setting is very important regarding the outcome. If you look at the curves on the left side, you have the event-free survival curves, and on the right one, you have the overall survival curve from the Patricia Cortazar meta-analysis, clearly demonstrating that yes, PCR is a surrogate marker of overall survival. And more interestingly, because we are discussing actually regarding the triple-negative breast cancer subset population, it is clearly demonstrated even in this field that in case of absence of PCR, so if we have residual tumor, there is a clear difference in the outcome regarding the event-free survival. And more interestingly, if you look at the curves, the events occur the first 5 years in the group of patients that do not achieve PCR. That means that absence of PCR might be a strong prognostic parameters for early risk of relapse in this triple-negative breast cancer population. If we move on now and we don't look just at the classical PCR or not PCR definition, I mean no residual tumor in the breast and in the axilla, but look at the very recent publication from the MD Anderson group and the Simon publication, the GCO in 2017, the risk of relapse according to what we call the residual cancer burden inside different PT stage, so that means post-neoadjuvant epsilon PT stages. If you look on the epsilon PT stage 1, there is no difference between the residual cancer burden 1 and 2, so very small residual tumor. If you look on the middle here, in the stage 2, and on the right side on the stage 3, there is a clear difference according to the residual cancer burden 1, 2, and 3. On the second part, epsilon PT stage 2, between 1 and the other one, and on the PT stage 3, between the residual cancer burden 2 and residual cancer burden 3. But more interestingly, they have also looked at all the subgroup analysis according to the different types of cancer, and this is just looking at the triple-negative group of patients. And when you look at the risk of relapse in triple-negative breast cancer according to the RCB, first, it doesn't seem that we have a huge difference between the pathological complete response and RCB1, but when you look at the RCB2 and RCB3, there is a clear difference regarding the relapse-free survival with a very important amount of events during the first 2 to 5 years. And at the end of the 5 years, if you don't have a relapse, that means that probably the patient is cured, even if the patient do not achieve RCB. So this point is very important. And if you look on the right side, you have then the cured, not looking at the relapse-free survival, but the distant relapse-free survival. That means that the majority of the event here are driven by the distant metastasis evolution of this patient that do not achieve pathological complete response. So the message from this analysis from the MD Anderson group is clearly that there is a high risk of distant relapse in case of not achieving PCR, particularly in case of RCB2 and 3 in triple-negative breast cancer previously treated in neoadjuvant setting by anthracycline and taxanes. And again, if you look at the risk of relapse during the follow-up, in this population of triple-negative breast cancer, the majority of the patient will have a relapse during the first 4 to 5 years. And when you reach year 6, that means that clearly there is no difference between the different subgroup RCB1, 2, or 3. The fact that this kind of relapse is very early is also for me a very strong argument to potentially use another type of systemic adjuvant treatment in case of not achieving PCR. So the second step conclusion is that the absence of PCR is clearly a bad prognostic marker in triple-negative breast cancer, according to the neoadjuvant trials in the meta-analysis, and according to the residual cancer burden and evaluated, particularly for the RCB2 and 3, increasing early risk of relapse, and mainly risk of distant relapse. So then the third step is, if we know that it's a bad pathological prognostic parameter, and if we know that this kind of parameter is also predicting the risk of distant metastasis on the very early follow-up period of first 5 years, do we have any argument to use more systemic adjuvant treatment in absence of PCR? And the answer is yes. It was presented 2 years before in the San Antonio meeting, but published last year in the New England Journal of Medicine. This is Masuda trial, the Japanese trial. The patient have received in the neoadjuvant setting 4 to 8 cycles of chemotherapy. They have all been exposed to anthracycline. Some of them have been exposed to anthracycline and also taxane. Then they have been operated, and in the absence of pathological complete response, half of them received capecitabine, between 6 and 8 cycles of capecitabine, and the other one, the control arm, do not receive anymore any systemic adjuvant treatment. So then when you look at the result, the benefit in overall population, and accordingly to the subgroup, according to the estrogen receptor positivity or HER2, is clearly in favor of capecitabine regarding the disease-free survival. You look at the left side, or on the right side, the overall survival with a statistical positive p-value and another ratio of 0.6. But more interestingly, if you look at the triple-negative breast cancer subset population, you have on the left side the disease-free survival, and on the right side the overall survival. And again, what you can look here is that you have a positive impact of the adjuvant capecitabine in this situation, comparing to the control group that do not receive in the adjuvant setting any other systemic treatment. I have just to remind you that actually including 5-FU is no more a standard of care in the neoadjuvant setting. And the other point is also that some of the patients in this trial were exposed to 5-FU in some FEC regimens in the neoadjuvant setting. So there is no argument that the patients that have been pre-exposed to 5-FU are not actually benefiting from the capecitabine in the adjuvant setting in this trial. So my conclusion is that yes, I believe that in case of not achieving PCR, we need to continue with an adjuvant systemic treatment, because neoadjuvant approach is the preferred one in inoperable triple breast cancer, who are candidate to receive chemotherapy, and the absence of PCR is clearly identified as a bad prognostic factor. And in fact, we have now at least one level 1 evidence phase 3 trial that in absence of PCR, additional adjuvant capecitabine improved the outcome for disease-free survival and also for overall survival. Thank you.
Thank you very much, Professor